How many of you have a hospital at home program? Can you raise your hands? Okay, even less. Okay, excellent. Well, before we can start talking about remote patient monitoring, we really got to start out by talking about the problem. Okay, so we're going to start by kind of flipping the switch on things. So we're going to focus on the green. And what does that mean? Are you turning my switch? Perfect. So let's talk about the problem, right? There's over 35 million hospital discharges annually. And look at what it's costing us in readmission rates, $15 to $20 billion. Are we really moving the needle here? Below that is a snapshot, and I'm just giving you a sample of a patient population. So we can look at charts all day long, and we can look at high risk, high costs, but where are we really gonna make an impact? So thinking outside the box, we really do still think in the box, believe it or not. We wanna target Part A by decreasing ER and inpatient admissions. Part B, right, decrease some of those specialist costs by having the primary care in the driver's seat, which means that our PCPs are gonna manage more of the conditions. Which are they? Because a lot of them are still referring patients out when they could be managing. We're gonna give you a couple of strategies you guys can use because we've been in the space since 2017. So we're gonna share some of those strategies with you today. Of course, we wanna decrease overutilization of home health, PT, and OT, but how are we gonna do that? When everybody gets it when they get a hospital discharge, whether they need it or not. Part D, medication costs are astronomical, especially on your diabetics, right? Because they have long duration insulin, not short, long, which means a lot of cost. So of course we want to switch them from high cost medications to generics where we can, because certain conditions require different medications. We want to avoid polypharmacy and of course institute a medication reduction, okay? But again, this takes a pharmacist to be part of your team. How many primary care providers have pharmacists on their team? Well, we're going to show you our solutions and our strategies and how we look at things. So focusing on the green means you're going to focus on the right-hand side of things first. So you're going to go for your low-hanging fruit. So why are we not managing our bradycardia, tachycardia, hypertension and hypotension, and of course your hypoglycemia and hyperglycemia, right? Because if we target that, you can move over to the right and it's over $90K in savings on your ER visits. Over $400,000 on your inpatient admissions. They're avoidable, a lot of them, correct? And then look at what you're saving over your total hospital costs, okay? $700K, that's a lot, which we can be utilizing for other things, right? Over 40% potential reduction. But you know what we're still doing? We're focusing on the yellow box. You guys see where the yellow box is, right? Now those conditions, as you see, we still have two of them in the green. So we have CHF and COPD. The only problem with those conditions is now we need a specialist to assist us, right, the primary care, to manage those patients because they're not as simple as your lower hanging fruit. But every single time that we're asked, who do we want to target, we always get the high risk, high cost in the yellow box, right? So we're pretty much ignoring what we truly can avoid. So that's why I'm here to flip the switch on you because this is what we target and we manage and we're going to show you how. But overall, you want to prevent avoidable future admissions and readmissions because our patients are chronic. So once they get to the ER, they're going to be admitted. That's just how it works. And then they're going to get home health if they don't go to the SNF. So now you're talking about a lot more avoidable costs. Now, if we target, let's say with RPM, your hypotension, tachycardia, hypertension, diabetes we can put in CGM nowadays, right? And get you to meet your diabetes and hypertension HEDIS measures. That's a triple measure, your diabetes measure, right? And most of the time your diabetics are hypertensive. So now you're meeting two measures at a time, okay? Now your star ratings go up, right? And you generate even more savings. Next slide. So let's talk about solutions, right? We saw the yellow box, so I'm giving you another little yellow box. So those patients are going to require more intense. So we're going to put them in a separate bucket because we need the assistance of the specialist. But we know how to manage them, right? So we're going to do an intense post-hospital discharge program. You need an interdisciplinary team. The office staff or the practice staff is not enough. You need dietitians involved, pharmacists involved, nurse practitioners involved in their care. You're going to need a village to keep these people out of the OR. And your primary care already saying we're doing enough, right? We do not have the time to be managing all these patients. That's why we take over, right? And I don't like to use the word take over because it's really a collaboration. So we're really there to assist the primary care provider and their team, whichever team they may have in place. If it's working, we just want to optimize it. We're not there to take over something that's really working. We're there to collaborate with you and build something that's going to grow, and more so generate savings and promote patient and provider satisfaction. So, of course, once you have those more intense patients, you have to talk about advanced directives if you want to do a hospital at home type of program, okay? Because that's really what you want to do, is have those conversations with those patients and pretty much say, once this condition becomes more severe, right, where do you wish to spend your last days? Is it going to be in an ICU full of tubes and lines, not seeing your family, especially nowadays, right? Or do you want to be at home and spend your days with your family, sleeping in your own bed, eating the meals you want to eat, right? So those are conversations to be had at the same time that you're what? Preventing avoidable costs. And of course, you have to have a collaboration with palliative and hospice. You have to have that on your team. How we do it is a handoff, right? We want to make sure that our patients stay in the loop with their primary care provider, but that they're getting the care that they truly need at the time that they need it, okay? Now, your green patients, right, we've been talking about all along, your low-hanging fruit, we could put those on remote patient monitoring after a post-discharge evaluation, right? So we have a plan in place for those 30 days, and we make sure they're not readmitted. And of course, we want to make sure they get back to the primary care provider so they could do their TCM. We go ahead and get their med recs done. We build a plan of care, and we collaborate with your team to make sure that we meet those patients' needs. Now, once we get them in remote patient monitoring or CGM or any program that we're managing, right, along with the primary care provider, you'll be surprised how quickly we could turn these patients around. We've gotten patients off insulin in 3 months on CGM. We've gotten hypertension medications decreased by half after a month of monitoring. Why? Because they're going to the specialist. They're not going to the primary. Do you think the specialist wants to fix them? No, right? Because then they lose a patient. Primary care is more about fixing the problem or optimizing. Sometimes we can't fix everything, but we could definitely make an impact and optimize them. More importantly, I will tell you, because my mother's also a patient. She was admitted at Delray. She had 3 stents put in. We put her on CGM. Within 3 months, we cut her metformin in half. She lost weight. She felt better. And do you know what she told me? Diabetes no longer controls me. I manage my diabetes. I gave myself a pat on the back for that one, right? Because as a provider, those are the words you want to hear. Because now your patient is engaged, right? We talked about engaged. We talked about adherence, right? So now she knows her numbers. And as some of you have mentioned, because I've met with a lot of you, during the past 3 days, I know what to eat. So there's a lot of education that goes along with remote patient monitoring, CGM, and having an interdisciplinary team that can really spend that time with a patient and really turn them around. Her hemoglobin A1C went from a 10 to a 6.5. It's amazing. Her friend joined the program, and we got her off 100 units of insulin a day. in 3 months. Think about what kind of savings that is. Direct savings, correct? Medication reduction. Of course, we also want to express the fact that these people are on the go now because they feel better. They start exercising, right? So CGM allows them to go on the go. And I don't want to give too much away because my partners here are going to talk about the future, right, of RPM, which they're all excited about. But I just want to empower primary care providers that we can really manage these conditions. We don't really need to refer that much to the specialist unless it's a trickier case or if a complex case, or as I mentioned to you before, they're in the yellow box. You're really going to need a little collaboration there, right, to manage your patients. Right, next one. All right, so now without further ado, I'll pass the baton over to Meredith.
Thanks, Jeannie. So I wrote my advance directive when I was 15 with my parents' help. I was your yellow box patient. Was. They didn't know what was wrong with me. They called from the high school and said, there's something very wrong. And they took me to the hospital and they did all the normal tests and they put me in a room on a Sunday night. I don't tell this story too often, sorry. And on Wednesday, I wrote my advance directive when they came in and told me I was gonna die. And then they said, what do you wanna do? We can put you on so much pain medication to take care of this that you won't feel anything until you die, whenever that is. Or we can keep you semi-conscious, and this is where you stay at 15 on telemetry. And at 15, everybody else is 70 and older. And so I said, I want to go home. And they said, you can't, because that was a really long time ago. And by Friday, my mother, who's a CRNA, said, I can take her home. I can put in a line and I can keep her comfortable. And they took me home and I couldn't be home because there wasn't technology to take care of me. And so they took me to Columbia Presbyterian Hospital to Arnold Gold and to a primary care physician who worked there. And eventually they figured out that I was an Arnold Chiari patient who was inoperable with massive nerve deformities and vagus nerve involvement. At 19, I had another stroke and loss of motor coordination center in my brain. And at that point, every doctor I tell that to goes, you're interesting, right? Right? Every provider is like, tell me more. And it feels horrible. It feels like I'm a guinea pig. I made a deal when I had my daughter with Jefferson Hospital in Philadelphia that if they kept my ex out of the room because it would have been upsetting for him, I understood what I was, what an anomaly I was, and if they kept me and my daughter alive, they could bring in students. My C-section was done in a stadium. There were 45 anesthesia students and 100 future providers in the room. That is not privacy, by the way, anymore. So, imagine how much I like the idea of being a guinea pig. I don't. And then we started CareNovtion. And our engineer said to me, I'm really gonna need you to put that CGM thing on so I can sniff how it works. No. And because I really like these guys, I put it on. And the alarms went off like crazy. See, a year ago I had another stroke and I just attributed everything to the Chiari. And I've kept going and I feel terrible most of the time for a year. And my primary care physician said, it's your Chiari malformation. It's increasingly symptomatic. And I went, okay, that sounds right. But with the CGM program, just because I put it on to be a guinea pig, finally agreed to do that, it turns out that I've had celiac disease that's untreated all my life, right? And I have reactive hypoglycemia. And I'm a pre-diabetic even though I'm thin and I eat really well and I don't eat a lot of sugar, because the vagus nerve and everything else has been doing things for such a long time that I have minor kidney damage already. And the University of Pennsylvania hospital team in my primary care said, without that thing, you probably would have dropped dead in a couple years of massive organ failure because we wouldn't have known how much damage was going on. But now we do. That was 2 weeks ago. And so since then, I've been managing my diet and on the celiac thing, and I feel better, and I'm sleeping, and my reactive hypoglycemia is getting better. So to all of the questions in your mind of does this work, Yeah, it works. Because I'm standing here today and I won't be dead at 53 for my 2 young kids, because that sensor on the arm and what this team is doing just figured out what was really wrong with me, right? And now both the Chiari and all those other issues can be managed, and I get to be in the green because I would have been one of your expensive patients. And nobody would have been able to figure out why. We would have all chalked it up to, well, it's that neuro thing again. So as much as I hate being a guinea pig, I'm pretty grateful standing here today on this stage. Try not to choke up over this, because I had kids late. I have an 11 and 7-year-old, and I'd really like to be around for them for a little bit longer. This wearable technology means that I can be up talking to you today with my sensors on, with my watches on, letting me know what my blood oxygen levels are. All this is really important because it allows my team to feed those data reports from Jeannie's team back to Penn in Southern California to tell them what's going on with me and help me manage feeling well and standing in front of you and running companies. And so while we can talk about the yellow and the green and all of the savings that we bring you, Gus asked me last night, other than the savings, what is our point? Like, I get it. And I said, no, your point is me. Because at the end of the day, every primary care physician and all of these nurses and providers, what they're really about is the people. They went into this so that people like me didn't have to say goodbye to their kids in a hospital. People like me didn't have to be sent home for hospital at home at 53 unless we were really bad, because I'm a cancer survivor too. Right? But I grew up in New Jersey. It must be the nuclear thing, right? That's why I'm still alive. So when we talk about what we're doing, some of the technology that is going to make this possible for your hospital at home or for your homebounds or for other folks is our diagnostic telehealth. That box is now a smaller backpack and can be rendered into a laptop hooked to a bunch of instruments next year. Those are some of the nurses in a long-term care unit that we service in California using one of the diagnostic telehealth cards. And what that box does, or the bag does, is allow a provider to go into a home, and if you see the little black square that you've got over there on the box, that's where their EKG can come up. And the doctors and other providers can be on those windows that you see a la Zoom. But they can also see all of the diagnostic level measurements going on with that patient without that patient necessarily having to come to you if they can't. That means that they can access their primary care anytime, anywhere. And in this day and age, that's important. I use that box quite a lot at a memory care facility where my ex-mother-in-law is, and they call me the girl with the yellow box. And they get to stay in their memory care facility where they're comfortable and still see the doctor that they are used to seeing, the person that they know, that they're comfortable with, or at least have a vague memory of being nice to them, right? And they remember me because of the yellow box. They have no idea who I am. They forget every week. They don't remember the rules to Uno either, I've noticed, when we play cards. So would you guys click that link, please? So when you click the link to go into the telehealth session, this is what you're going to see. And if you joined that session and a teleclinic was in action, right there you'd be able to see all of those instruments and the cameras for as many folks, right now up to 9. You can put a stethoscope on the patient anywhere, and the doctor can hear it through the speakers on their computer. On the other end, on their iPhone, on their Android device. It works with everything. And I'll let Gus talk about interoperability a little bit. Would you guys mind going back to the slide? So Gus, I'm going to turn it over to you for technical.
Thank you. It's actually a real privilege to be here this morning. I've been around. You heard I'm the engineer. And I've been in the industry for quite a few years, doing hardware design, software development, and I love technology. I'm kind of a technology junkie. I like to see what's new. I like to see what we can do. And technology, to a great extent, is great. It's helping us. All of you have your phones, and you do quite a bit of things with the phones, but it's also failing us, because technology it's supposed to help us, and it doesn't always work out that way. Especially as you get older and you're in a condition that you're not able to use the technology the way that it is available, you see that it's something that it's there, it can help you, but you can't use it. So we have this company called CareNovtion, comes from Care Innovation, And what we're looking at is how can we use technology to apply it in the right way, create what is needed to be able to assist in a way that is not going to interfere with your life, but it's going to assist your life. As I go around the room and I'm talking to different people here, I see that all of you care about the outcomes. You care about making a difference. And that's really great, right? We've heard stories here how technology can make a difference. But we also see that there's a lot of challenges. Some challenges are simple. She put on a sensor, and she was quite a trooper using it, and she didn't have a problem with it other than not being happy about putting it on in the first place. But we see people who require the sensors, but they don't want to use them because, guess what? It's not the right color. Jeannie here, she's shared with me that somebody would not put it on because it's white and it sticks out like a sore thumb. So what can we do to help that? Well, one of the things we looked at was to, you've all seen the patches that come that you can put on top of the sensor to hold them in place, probably. Well, why not have patches that are matched to your skin color? So that's one of the things that I said, hey, we have this device, it can measure your skin color, we match it to a Pantone color, then we go to the printer and we can print them in your skin color so that now you cover your sensor and it won't be that noticeable. That's one thing. We see that there's other issues that are more complex. For example, you have the sensor, and my partner here, she's absolutely disciplined and great in having her phone and taking her phone to the sensor and measuring getting the results, reading the data. But not everybody can do the same thing. And even her, when sometimes, life gets in the way and you forget to do the measurement, the alarm goes off, then she goes and she measures it. Well, being proactive and monitoring the data all the time shouldn't be something that it's requiring you to do it. It's what we're thinking. And we're looking at ways to improve that by having the sensors in place, having technology that is wearable that goes next to the sensor to now be able to capture that data without you having to do anything. And we know technology is advancing. There's new sensors that are coming down the road, but you still have the need for a phone or a device that it's nearby. What happens if the phone is not there? What happens if you forget to charge it? Now we're able to put with the sensor a little radio that is able to bridge the near-field communications that is needed to activate the sensor, the Bluetooth that is needed to read the data, and bridge it through cellular. To take that data to a place where it can be actively monitored all the time by a server in the cloud. That can then let them know when something is needed, when something needs to be paid attention to. And they can jump into action and take care of that individual without having to worry about monitoring thousands of individuals using technology to help us all. If you guys have any questions, I like technology, happy to try to answer any questions. That's what we're trying to do. Personally, I've always liked the challenge of saying things that people think are impossible to do, things that are very difficult to do. If you have ideas, if you think of areas where technology can help you, I'm more than happy to hear what you have to say and see if there's something that we can actually do to use technology to benefit you.
If I could just make a comment, is Meredith, right?
Yes.
Meredith, I just want you to know your testimony was amazing. And I hope everyone in this room will stand up and applaud you and honor you right now.
Thank you. Wow, that was a hard one to tell because I don't like to talk about it. Thank you.
I just want to add, Gus has been instrumental because we can put a sensor on everybody's arm, but unless they scan, we don't get the information. So that was an issue I was having, right? Plus with arthritis and all kinds of issues the elderly have, sometimes they can't scan, right? We need the family member or the caregiver to scan the sensor for us, right? So with Gus's technology, it automatically fits into the platform. So we're able to capture all those readings. Therefore, again, putting the primary care in the driver's seat, right? Because now we don't need to refer to endo. We really don't. We can really manage these patients. And again, sometimes primary care doesn't realize the value that they really add to the piece of the puzzle. So primary care involvement is crucial. But we need to motivate these providers, as some of you have mentioned, sitting over here. We do have to engage you because you really do make such a big difference. Once patients have a provider that's innovative, that's looking to assist them with their condition, that puts not only themselves in the driver's seat, but also the patient first, they're never gonna leave you. They're not. Because you just made an impact on that patient's life. You took them from a patient to a customer now, right? They no longer need that label of patient because wearing a sensor on your arm, I mean, for those of us that don't have to wear one, might not seem like a big deal, but for a lot of patients, they have mentioned, can you make it on our skin tone? Why do we have to wear these buttons on our arms, right? So we went the extra mile, and through Gus, we developed glucagon, right? So we're gonna match it to your skin tone because we wanna really promote adherence, which was a term we heard about, right? In our first day that we were here together. And adherence is crucial. It really is. But again, we have to meet the patient where they're at in order to start making an impact. So it's really about communication, collaboration, and teamwork. Yes?
And essentially, we talked to physician by, and we spoke about all this and what's going on. So two things, I don't know that doctors have ever walked into a patient's home to try to care for them. So the job that you all do is just unrealized by a physician. It becomes just a unilateral kind of thing. And that's something that, would be nice if they become aware. But you mentioned something about if you're in there and you're taking care of one of our patients, that we could link doctors up to the Zoom meeting and have them become part of the home visit, which I feel is what the accountability part of getting doctors to do is really important. And the other thing is, it's a 24-hour kind of thing, and you're not there 24 hours. So if we set it up smart, then we could basically, if we get a phone call, save ourselves a little bit of trip to talk a patient off the ledge. And the last thing I'm going to say is having the ability to, whether it's a glucose monitor that they can look at and see their sugar is good, or even a blood pressure machine, which people begin to have a sense of well-being and safety, and that post-traumatic stress issue from a hospital discharge, especially on a spouse who has now people who are there to help, is invaluable. So I'm not a big in-home kind of person because I did it for many years and it failed. But I think the time now is that we're finding that the doctors are meeting up with patients in their offices that are too sick for them to take care of. And the only solution that they have is to send them to a multitude of specialists, and then fragmented care occurs. In the patients that are too sick to take care of, it might be better to take a stab at a few weeks of home care. And with your help and the doctor's understanding of what can happen, they might understand what that means. What happens between two visits is what gets patients better. That's what you're trying to do. So I'm interested. I think I'm going to go and try to look further at how we could utilize this. But I always say when the ACO is, we have low-hanging fruit in ACO that we've all taken care of. We make a lot of money. And what is our second, third, and fourth, trick in the bag that we could use? And the third thing is that it's a billing issue, right? So most of these things get billed directly to CMS. And that's, you can quantitate what it would cost again, but getting a person who's not comfortable being home after an admission could either last 6 months or a year, or it could be resolved in a few weeks with some real, attentive care. And visiting nurses are not the ones. So, good job.
Thank you.
Yeah, thank you. I did wanted to point out that you mentioned the glucose sensor. We do have other devices that we're looking at making available for measuring blood pressure, for monitoring your blood saturation level, your oxygen saturation level. And we have a cardiologist who is also not here today, that it's part of the team, that wants to use technology to be able to realize when there's potential congestive heart failure. And he says that we can 100% predict it with the weight and measuring the inductance and things like that. So we're here to help you. We're here to work with you to have better outcomes.
Any other questions? Say that again. I couldn't hear the last.
Is there a differentiator? Do you observe the competition not doing it so right? And is there something that you do differently?
Yes, thank you, David. We actually do. We've actually inherited primary care providers that had an RPM program, and it wasn't working, and I will tell you why. Our team is all medical. Everybody that you're going to get a hold of is medical, except for Gus and Meredith, but they're not part of our interdisciplinary team, okay? Everybody in our interdisciplinary team is either a medical assistant, a registered nurse, a pharmacist, a nurse practitioner, or a physician. So anytime you get a hold of us, we're gonna fix or optimize the problem, right? We wanna fix what we can. But this is the thing, to David's point, is you're gonna have regular coffee or you're gonna have an espresso. We're the Nespresso, which means we go the extra mile. We're gonna be there, we're gonna answer the phone. When we can't get a hold of a patient, we do a home check. So we're gonna find out what's going on with that patient. Okay, if we have to do a welfare check, we go through the primary care. They give us the okay, we go in and do a welfare check. We go that extra mile because we want to keep that relationship. Remote patient monitoring is all about adherence. So you have to call these patients, right? You're high risk, weekly. We do that for you. We're always in contact with them. Did you take your blood pressure? More importantly, we triage the patient for the primary care, David, so they don't have to do that. So we go through the vitals, we look at the trends, we go, oh, you were high here. We call them. Did you take your medication? Do you know how many times we hear no? Take your medication, retake your blood pressure an hour later, right? And then once we get a reading, I want you to check it again later on when you take your PM dose, because I'm gonna watch that trend. If they were high, then they were low, right? And then they stabilize. I don't need to loop in the primary care. They just didn't take their meds. So next day, they already know we're gonna call them, right? So they take their medication, right? Because they don't wanna be the naughty patient. So now, if we have a patient, and I will tell you what we see in our program, David, is they're high, right? They start really high with us, and then they start dropping, right? So they get to a certain level where for them, they might be symptomatic, although the pressure's really not that low, but for them it's low, right? Because it's individualized. That's when we loop primary care in, because we made that call and we asked, are you symptomatic? And if you are, call us. That way we can do a telehealth with your primary care. And then we start the process of Medicare reduction. That's where it fits in. We also tell them sometimes, if you're symptomatic, right, at this level of blood pressure, wait to take your medication, let's talk to your primary care and see if you need it, correct? So we, like I said, our job is to put the primary care provider in the driver's seat, but give them the tools to be able to make those decisions.
Thank you, Dr. Gonzalez.
I wanted to say one more thing about the differentiator. I know our time is up, so we can't take that much time, but RPM, we're talking about a sensor on somebody, and that's intrusive, right? But RPM is becoming more and more ubiquitous in a way that it's not going to be intrusive anymore. You can have cameras looking at how somebody walks and be able to realize that they're now having some type of decline. You can have the ability to measure their temperature. You're able to monitor their breathing. Soon we're going to be able to even look at their heart rate just from a camera. So yes, it's intrusive in some ways. We need to be careful where we put this technology in place, but we're going to be able to use all that technology to monitor people, monitor those who need the care without interfering with our lives.
Well, thank you, everyone. It's been an exciting presentation.
Thank you.
And thank you, Meredith, for sharing your story.